Thank you for this opportunity. Now, I would like to present my case with the title External Scleral Fixated Intraocular Lens as a Management in Aphakic Eye. As the introduction, there are various techniques of secondary intraocular lens implantation or exist, especially for aphakic patients without adequate capsular support. Loss of the capsule can occur in the context of complicated cataract surgery, trauma, or inherited conditions such as Marfan syndrome or pseudoexfoliation. Current choices include scleral fixated IOL implantation, become popular both with or without suture. The one of suture technique is ab external. Now we're moving to the case. A 68 years old man came with blurry vision on the left eye since 1 month ago. He had history of primary angle closure suspect and posterior subcapsular cataract on left eye and managed with intracapsular cataract extraction in January 2021. From the ophthalmology examination of left eye revealed uncorrected visual acuity 1/60 with the irregular updrawn pupil with the diameter 7.4 mm and 5.3 mm, and the lens was aphakic. The best corrected visual acuity with spheres plus 12 diopter, cylinders minus 0.75 and 84 axis was 0.4 Voltef. The patient underwent secondary IOL by using 3 pieces IOL with up external scleral fixated on his left eye, as you can see in the figure 1. On the figure 1, first we do the conjunctiva paretomy at the superior and then do the scleral tunnel. We determine 2 points of fixation, in these cases at 2 and 8 o'clock. Entry points for both needles are measured 1 mm posterior to the surgical limbus. The straight needle of 10.0 polypropylene suture is inserted at this point. A 26-gauge hollow needle is inserted from opposite side. The polypropylene needle is docked into the hollow needle and taken out from the opposite side. The suture traversing the eye is externalized with the use of second instruments inserted through a superior corneal scleral incision. The suture is cut in the middle and each end is tied to one haptic of the IOL. The IOL is then introduced into the eye and maneuvered posterior to the iris with the haptic resting in the ciliary sulcus while the suture are pulled out, and then make a tight of suture. Power IOL determined with plus 24 diopter with a target of refraction with ametropia. 1 day postoperatively, the uncorrected visual acuity was 0.08 with the pinhole 0.125 with good concentration of scleral fixation IOL. At the first month postoperatively, the best corrected visual acuity with spheres minus 1.75 diopter with the cylinders minus 1 and axis 50 with 0.4 on the Snellen chart. For this discussion, the aphakia with inadequate capsular support can be seen in several conditions. Technique of introducing two suture loops for scleral fixation of an IOL by up external procedure, which proves safe and effective. Scleral fixation of IOL in the posterior chamber, although technically demanding, allows good visual outcome. For the conclusion, up external scleral fixated IOL implantation is an effective rescue procedure for eyes with deficient capsular support. Therefore, surgeon choice remains important. Differing surgical skills are required for the varied technique, and individual surgeon will select their surgical approach accordingly. I truly appreciate your attention. Thank you very much.